So I'll just give you a little background as to where this came from and where we started. We all know about COVID. I don't think I need to talk to you about that. But when I started seeing cases, they seem to be a slightly different type of case than we were seeing before. And I think it's only going to get worse and worse as we go forward in this pandemic, that people are not going to be coming in for routine care. And then therefore that's going to be something that we're seeing a lot more emergent cases, more abscesses, more jaw fractures from pathologic disease, and things like that. So I think this is a very important place to start. Where I would really like to move in the future is to talk to things about home care. What can clients do at home? That's something that I'm looking forward to doing in a future webinar. And we'll talk about periodontal disease. We'll probably talk about equipment and pretty much everything that relates to it. But I really thought that the emergency veterinary dentistry would be a very good place to start because it is, well, it's what we're supposed to be doing right now is really emergencies, and it depends on who is doing it. So, okay, everything looks good. So we are, I think we're just a few minutes past. I gave a couple people a few minutes to get on going here. We are currently at 212 participants, which is phenomenal. So I tell people all the time, if they're late, it's their fault, not yours. You guys were here on time. I'm sure you have very important things to do this evening. So here we go. Let's talk about emergency veterinary dentistry. Okay, so really quick, if you're out there seeing emergencies, I have written books, and I tell people all the time, if you want to know something about a subject, write a book on it. And all of these pictures, or most of these pictures, are out of the emergency medicine book, and it is available at Dog Beach Vet. I'll send you guys all a link if you want to look at it and think about ordering it. But most of these things are covered in even more detail within the veterinary dental applications of emergency medicine. So I just have to say this, I own numerous things. Vet Dental Rad is a telemedicine company. The training center here, unfortunately, it's in a pause right now, which is why we're doing stuff like this. Obviously our main practices. We do have a sharpening center. If you guys are having dull instruments and it's something you want to do, that will be something that I will probably cover in a future webinar. Sharpen instruments at home. I do speak for numerous companies, including Covetrus, but I will tell you that Covetrus is not, they're not sponsoring this in no way. They just literally jumped in at the very end to help me give this to you guys. So again, I would like to thank them very much for their support in putting this lecture forward. So as we all know, COVID has changed the way we practice, plain and simple. Like I said earlier, clients are much less likely to present for preventative care. So what does that mean? Well, the gum disease is progressing. Remember February, National Pet Dental Health Month? It was just starting then. Depending on where you are in the world, it was probably already taking effect. I know it was here in California, just starting. So what's happening now is that our patients are not getting the preventative care. And so what's happening is that, as you well know, if you don't treat something, basic, when you first start seeing that first cough, then eventually it turns into heart failure. And what is the client doing? Taking them in at 3 o'clock in the morning to the emergency clinic. Happens everywhere. So because we're just not getting this done, it's going to create an emergency. The other reason that I really like to have this is that I believe that emergency vets, especially if this thing drags on, are going to be dealing with dental issues that they wouldn't normally treat. Because again, us general practitioners generally are the ones that treat the dental disease. But in this situation, ER vets are going to see it. Why? Because a client's going to wake up at 3 o'clock in the morning concerned about their dog. And so they're going to take them in. So this is critical to educate everybody so that they can properly treat these patients on an emergent basis. If any of you guys have seen me lecture before, you know that I talk all the time about dentistry just being way misunderstood, lots of misconceptions. And we went through this as I was developing this lecture, and I'll be honest, I'm really excited about this lecture, how it came together. And I worked with Dr. Stewart, my significant other, and she's really smart in this type of stuff as well. She's like, oh, you shouldn't talk about that because people don't think that's an emergency. And I'm like, But as a veterinary dentist, it is, damn it. And this needs to be treated now. So we're not going to talk about persistent deciduous teeth tonight because it's not considered an emergent problem, but it's causing issues. So some people are going to say, well, that shouldn't be treated. Other people will. I'm going to tell you what I think. This is Brooke's opinion. Everything in here is Brooke's opinion. I'm going to tell you what I think about it. I'll use references where I can. And there's a lot of myths that are in there as well. I want you guys to remember, guys and gals, sorry, these conditions are painful. They hurt. You know, these animals have been suffering, but they very rarely show clinical signs. So if you see something when you're doing an oral exam on a patient that's presented to something else, you got to know that they're painful and they need to be treated. So that's one of the big things, is to talk to your clients about how to take care of their patient and why it's important. Another reason why I think this lecture is so important for everybody, especially ER vets, the initial care in an emergent situation with these patients will have a direct relationship with the eventual outcome. So I'm not going to talk a lot of details about how to treat this on down the line, you know, root canals, extractions, there'll be things in there, but really, how do we take care of this patient and get them to the right place for care? When is that care when should that care be taken or given? And then client education, and we'll talk about this in numerous places. Proper client education is critical in these situations, not only to set up expectations, but also so they actually follow through with the correct care. We'll talk about that, especially when we get to abscess teeth. So what we're going to talk about is the true emergencies for the most part. We'll talk a little bit about what this needs to be done soon. So what are we going to do? We're going to talk about triage and initial care, diagnostics, recommended definitive care, and then client education and prognosis for these different things. So, and again, there's not very many things that are a true dental emergency. They need to be treated soon, but they don't need to be treated now. Usually within a day or two is fine. You know, again, bleeding out of the mouth from trauma needs to be handled, but definitive care can usually wait. And a lot of these true emergencies, to be totally honest, patient's not stable to undergo anesthesia today anyway. So a lot of this is going to come down to proper diagnostics and supportive care. But there are some things that I think you all are going to learn that's going to help your patients feel a lot better and let you be a lot more confident in treating these. Here's the big one. I mean, where are you going to start with this? Jaw fractures. That's probably the big thing that we're going to see on an emergent basis with these guys. Now, a little bit less likely because people aren't out and about as much, but it still could happen. We'll talk about that in a little bit. But this is a bilateral mandibular fracture of a German Shepherd dog. About 4 years old, was hit by a car. Why was he hit by a car? Because he was chasing the tires and tried to bite it and broke his jaw. Here's another dog, just classic. You can see the soft tissue disruption. If it's bleeding significantly, obviously you need to go in there pretty quickly and do something. But in general, this could wait a day or two. Cats get it as well. This could be a TMJ malocclusion or a TMJ fracture or dislocation, but it's probably a fracture. I'll be totally honest. I can't remember the last time I saw a true TMJ luxation. It's almost always a fracture, especially in cats. So the old pencil trick of trying to put it back together, it generally doesn't work just because it's usually a fracture. We'll talk about imaging and how we can better take care of these patients from there. So, generally it's a result of trauma. And again, I want you to remember, jaw fractures don't need to be handled now. It needs to be handled quickly. Especially if trauma is involved, because you need to stabilize the patient first. So what I'm talking to you guys about right now is this dog was just presented to me. He was hit by a car. He fell out of the something, whatever. He's injured. What am I going to do now? Not what am I going to do in a couple days? What needs to be done today? Here it is. Your initial care, it's not rocket science. I tell people this all the time. Dentistry's not. Please do a full physical and neurological exam. I know that we're concerned about animals as fomites, and there is a small chance cats worse than dogs, but please don't forget to do a full physical, because these patients in general have undergone trauma. You need to auscult the heart and lungs. You need to do an abdominal palpation. You need to do a neurologic exam. A lot of these patients will have head trauma, and again, you don't want to be anesthetizing an animal that's got head trauma, so do a good full physical exam. you're going to see that second line about 50 times tonight. Minimum database, minimum database, minimum database. Please, you got to look for anemias. You've got to look for, for bilirubin in case they had, some kind of trauma and they're bleeding. Anything like that. Look for kidney problems, liver problems, anything like that that's going to affect that patient's initial care. Because again, what's the next line? Pain management. And that's your other thing. Those two lines right there. You guys, half of you can walk away right now if you remember those two things. Do a minimum database. Ideally in-house. If you're not doing real-time care, this is a great time to do it. Minimum database, and please, 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 pain management for these patients. And why is the minimum database important? Well, the best drug, pain management-wise, for trauma, NSAIDs. NSAIDs are amazing. Use NSAIDs on these patients, especially dogs. But again, got to make sure that their internal organs are working well. On initial care, skull films, why? Because they don't require anesthesia. Dental x-rays, unfortunately, require anesthesia. Skull films, you can get an idea. They are not diagnostic for most things. You need to have dental x-rays. I can't stress that enough, but that's for definitive care. Right now, we're doing triage. We're getting that patient taken care of in the emergent situation. So here's this is courtesy of one of my good friends, Dr. Jared Gabor, because I don't usually take skull films. Thank God we have CTs that we usually will do, and we'll get there in a second. But you can see the fracture where the red arrows are pointing there. Pretty obvious distal mandibular fracture going on in that spot right there. So what are you going to do? Well, we already talked about pain management, work that patient up, maybe take chest x-rays as well to make sure that there's no, pulmonary edema or trauma or anything like that. And then you want to provide some temporary stabilization. Now, you guys have probably seen over the years in all of these textbooks, surgery, dentistry, a tape muzzle. There's all these ways to put it on. Dude, I will tell you, they are miserable to place. Not only are they miserable to place, they also generally require anesthesia to place. I don't use them anymore. The problem with tape muzzles, not only are they hard to place, they take time, they can cause inflammation. You can't easily take them off, and you can't easily replace them once you've taken them off. So the problem is, let's say you sedated this dog. Here's a puppy on the left, this cute little Labrador. He broke his jaw, so you're going to place that tape muzzle until Monday when they go see the dentist, and you're going to keep him more comfortable. And here's the problem: he wakes up and vomits, regurgitates. Well, now you're in trouble. Or he goes home. He's a puppy. What's he going to do? He's going to make a huge mess all over the place. And then how are you going to clean it? You're going to get stuff up underneath there. My recommendation, this is something I came up with many years ago, a soft nylon muzzle. The dog should be able to lap through it. So open up enough, so they can breathe. They should be able to open up their mouth enough so that they can lap gruel. So again, I'm not shilling for anybody, but Hills AD is a great diet to use for these, mixed up into gruel, but Rebound as well, anything like that, high nutritional value, mixed up into a gruel so the dog can lap and drink water. Get a nice soft nylon muzzle that opens up enough for them to lap and to breathe. Have the client get 2 or 3. Why? Because it's going to get dirty every time the dog eats. And then what I do is I feed the dog, and then I hold the animal's mouth, take that one off, put the new one on, put that one in the washing machine, and then every day you just rotate it. Every time the dog eats, you can replace it with another soft muzzle. Keeps it clean, avoids the dermatitis, and oh, by the way, it's really quick to get on and off if you have an emergency, whether it's vomiting post-operative, or maybe they can't breathe well. Again, they might have nasal trauma. They may not breathe very well. So I really like this soft muzzle as a alternative. Definitive care, well, it's going to be ideally with a veterinary dentist. If you don't have one in your area, surgeons can do a decent job as well. But really, dental radiographs should be done. And what you're seeing here in these x-rays that I think is so important and so many people miss, these, and we'll talk about this more in a minute, these are pathologic fractures. So they were caused because of bad gum disease. Now, the one on the left, that's got bad gum disease to the second, third premolar, and it broke from trauma. But that one on the left, that's a pathologic fracture because of chronic dental disease. So you've got to have dental x-rays to adequately fix jaw fractures, because you're just not going to know what's going on in there as far as other pathologies that might cause it. And CTs, they're always the best. They're going to give you the most 3D reconstruction. Again, this is courtesy of Dr. Gabor, because I don't generally always take CTs, but it's never a bad idea for maxillofacial trauma, especially if you have it in your area and the client can afford it. As just really quick, as far as definitive care, fixing it down the line when the patient's stable, most veterinary dentists prefer minimally invasive methods. Hey, anybody that has a question, I see some people raising hands, go into the Q&A. You should have a little Q&A button, which I'm going to pop on as soon as I finish with jaw fractures, and I'll answer any questions. So if you have any questions, please put it in the Q&A session, which you should see on your little sideboard, and I will answer those as soon as I get done with here. Definitive care, most veterinary dentists prefer minimally invasive methods. This means we don't do plates, we don't do KEs or external fixators, because it's really easy to avoid things. The way I fix 98% of my my jaw fractures is with an acrylic splint. They're really nice. You put them on plus or minus wires, and when you put them on in there like that, the nice thing about intraoral splints is that when you come back to take this off in 6 to 8 weeks, you don't have to go in surgically. Yes, you do have to anesthetize the patient, but all you do is cut it, score it in a few places, pop it off, and there's no surgery, so no tissue disruption. The other beautiful thing about it, if you can do it with this, you're not putting any hardware. You're not drilling into the bones. So you don't have to worry about the roots. You don't have to worry about the mandibular canal or anything like that. If that's not going to work, because as you can see in the right picture, there's no teeth. If you don't have any teeth, you can't do an intraoral splint. And because basically when you do this intraoral splint, going back for a second, what you're doing is an external fixator where you're using the teeth as the pins that go in. It's a beautiful way to do it. I've been doing it this way for a long time, and most veterinary dentists do. On the left is a circummandibular wire for a symphyseal separation in a cat. And this is where we really don't like putting in these invasive things. And this is really where some veterinarians, will be using these KEs. And, this is a case on the left where they'd had numerous surgeries. And the reason it didn't heal, and we'll talk about this again in a minute, was it's a pathologic fracture. You can see the infection there. And then on the other side is a plate. You can see how invasive that is. If you can avoid that with an intraoral splint, it just does really, really well. So I'm going to pop up here before I drop onto pathologic fractures. I did see a couple questions. Yeah, I don't, as far as IM pins, I don't know any veterinary dentists that do that. It traumatizes the mandibular canal. It can cause major issues in there. So I don't know anybody that, veterinary dentists personally, that use IM pins for mandibular fractures anymore. We generally go for those minimally invasive ones. And the type of splint that I use, there's two different ways you can call it, intraoral or interdental. Basically, all you're doing is gluing the teeth together. And what we use now, that picture that you saw was methylmethacrylate, which would be the same thing you'd use for an external fixator. Nowadays, we use a product called MaxiTemp, which just happens to be a Covetrus product. MaxiTemp is it's a cold curing one. If any of you guys have used methylmethacrylate, it gets really hot, and that can burn the teeth and burn the tissues. So most veterinary dentists will use the MaxiTemp, which is a temporary crown bridge material. That's what we typically use. So pathologic jaw fractures. This is something that we generally do as veterinary dentists. We see these little old dogs that have not had their teeth taken care of, so they end up getting into really bad periodontal disease. And I think this is a really important point for you guys to understand. I talk about this a lot. So when you're not seeing this care on a regular basis, these little dogs get worse periodontal disease. And especially if, again, we're not getting the routine care. So what you can see on the left there's like a 0.5 millimeter of bone there. That jaw's waiting to break. And then on the right side, you can see all that bone loss. You got that nice hook. You got all that bone loss. So these teeth are going to break. They're like a toothpick of bone. These jaws are going to break really, 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 really easily. And so, and we see it all the time with these small breed dogs. The number one time we will see it is with big dog, little dog, and when they're fighting about food. Why do little dogs break their jaws and big dogs don't? Why didn't we know about this 40 years ago? Because we didn't have 4-pound Yorkies 40 years ago. We had 10-pound Yorkies 40 years ago. And so the problem is we breed these animals smaller and smaller and smaller. You know, when we do it, you wouldn't see a 2-pound Yorkie running around out there. You wouldn't see, I saw a 0.8 kilogram poodle a couple months ago. That's not a dog. It's a hamster. It is. And the problem is when we bred them down, we shrunk their teeth, or excuse me, we shrunk their jaws more than we shrunk their teeth. So why little dogs tend to break their teeth is shown in these 2 x-rays. On your left is a Labrador Retriever that weighs 35 kilograms. You can see that lower first molar, and those white arrows are pointing to about 4 centimeters of solid cortical bone below that tooth. You cannot break the jaw of a Labrador. Trust me. We were trying to do a lab with cadavers, and my ex-football playing, college Division II football playing resident couldn't. You're not going to break the jaw taking out the lower first molar of a large breed dog. On the right is a 7-pound Yorkie, or poodle. I think it's a poodle, 7-pound poodle. He's got 1 to 1.5 millimeters of bone below that mesial root of that first molar normally. So therefore, when you go to take these out, you have to worry about breaking the jaw, and that's regardless of having bone loss or not. So why is it important to know that you have a pathologic jaw fracture? Well, because if you try and fix it normally, like on the left there, because you didn't, whoever did the surgery did not know that these teeth were infected because they didn't have dental x-ray, you must remove the teeth to allow it to heal. And so if you don't have dental x-rays and you don't know about it, you're going to fix it. And that picture that I showed you with the KE earlier was the same thing. Infected teeth, you didn't know about it, it's never going to heal. You must remove the infected tooth roots in order for it to heal. So the knowledge base, how you would know about if it's a pathologic fracture, here's some clues. You're going to know with a dental x-ray. CT would help too, but dental x-rays are going to be diagnostic. But what would be a clue? Old dog. Little old dog, a 9-year-old Labrador is probably not going to have a pathologic fracture. You can get it, oh, by the way, in boxers and pugs with the dentigerous cysts. I've seen that. But in general, dogs with pathologic jaw fractures are going to be a little old dog, okay, usually under 10 pounds, especially under 5. Okay, and they're going to be a questionable history of trauma, meaning he wasn't hit by a car. He fell down the stairs, he fell off the couch, he was bit by a big dog. It's not going to break a normal dog. And the dog's not going to be acting too painful because it didn't take much to break it. So on the right is a properly treated pathologic fracture by one of my residents. You can see we removed the distal root, did a root canal on the front root, on the mesial root, which is that green arrow pointing to. You can see in the top picture the pathologic fractures, all that bone loss is the blue arrow, and you've got some infection, which is the yellow arrow in the periapical space there. And then the red is the healing at the end. So let me go back and see if there's any questions here. I do see some more. Let's see. Well, as far as Heather, appropriate options for GPs to pursue, it's hard. Fixing jaw fractures are really, really challenging to do. Even for us as specialists, they are. In general practice, intraoral splints are really the easiest thing to do. The other thing I would do is wiring. That wiring I show would be a really good thing to do about that. And like to follow up on that, yeah, I know not all clients can afford it, especially nowadays. That's where you would talk about, you guys can certainly, try to do the intraoral splints, but if the client can't afford it, the muzzles actually work pretty well. Recheck protocol, great question, Aaron. I will recheck that animal, and I'm not gonna go really deep into a lot of this because of time. But when it comes down to any jaw fracture, I check that animal at least every other week. I'll evaluate them, make sure everything's healing. Here's a critical point. You need to weigh that patient, especially small breed dogs and cats. Old small breed dogs and cats may not eat, and they will not heal unless they're getting groceries. So you must be maintaining to gaining weight. And I've had a few patients that have not healed and have not done well because they weren't eating very well and they weren't eating at all. So therefore, Therefore, in that situation, we need to weigh these patients. It's a big thing. Big dogs will typically eat. Little dogs can be persnickety. And then to answer the question about why did we root canal that tooth? Well, because we needed that tooth. I'm going to go back to it. Someone asked about why we did a root canal on that tooth as opposed to just extracting it. And let me go back here. So the reason for that is what you can see is that that first molar for the initial intraoral splint provided a lot of surface area for bonding our splint to. So we wanted to keep that mesial root. When he came back to remove, so we did a temporary root canal on it, medicated it, and then when he came back in 6 weeks to have all this removed, well, do you really want to put trauma onto that area? It's a big root to extract. It's periodontally healthy, so we didn't want to take that out. So that's why we went to a root canal, but extraction would certainly be advisable. I'm going to move on to luxation and avulsion. I'll come back to some questions. I just don't want to run out of time here on you guys. So here's a tooth luxation, pretty classic. Luxation is it's pulled out of the tooth, or out of the socket, but it's still into the mouth. Avulsion is completely ripped out. So avulsion is something that we don't see tremendously often. Luxation is something that we do see. Typically, it's going to be the result of a dog fight or chewing on a cage. There's really two things that you've got to consider prior to replacing the teeth. Number one, is the tooth periodontally healthy? And number two, what are your client's expectations? We're going to talk about both of these. This side does this slide look familiar? Yeah. Do a full physical and neurological exam because they probably had trauma, run a minimum database, give that patient pain management. There you go. That's 90% of what you guys need to do for these patients. You do that and you've done most of your work already. Again, initial care, just like I showed you before. If you're going to have that client come on and have it replaced, tape muzzle or soft muzzle is certainly a good way to make that patient comfortable. Definitive care. What are your options? Well, for a luxated tooth, extraction is certainly a viable option. Take it out, close it, it's totally fine. A lot of clients will want to save these teeth. And if they do, then they need to come out and be saved. This is definitely one that needs to be handled by a veterinary dentist. I'll explain to you why. First thing is we need to have dental x-rays. Why? Well, what kind of success rate are you going to get out of those lower canines that have 99% bone loss? Gee, I wonder why these got luxated. And then on the right side, what you're seeing is that dog was presented for a luxated tooth, and it was a show dog. And the client really wanted me to save the tooth. And I'm like, great. So I got him under anesthesia. And I'm like, it's not a luxation. That's a shattered root. That ain't going to work. So if you'd have put that back into place without a dental x-ray, yeah, that would have not gone well for anybody involved. So how do you fix a tooth luxation? OGPs out there, you can do this. This part is not hard. This is what we would do, and I could do more on this if you guys want in the future. This is just a figure 8 wire. You can see the wire there on the canine on the right side. It just did a figure 8 wire, covered over it with acrylic. It's an acrylic splint. Now, some people, highfalutin people, will talk about doing a movable splint, something that gives so you don't get ankylosis. I've never done that. Don't worry about it. Works just fine. So you guys can all do this. Here's the problem, though, and this is where we get into an issue, is that you need to do a root canal on these teeth. This is the critical part of client expectations. Before you send it to a veterinary dentist, before you send it out of your clinic and say, well, you can have this tooth fixed, talk to the clients about the fact that, number one, after we're going to do an acrylic splint and we're going to put the tooth back in, but that tooth's going to die the vast majority of time. So therefore, if we're going to fix and maintain a luxated or a avulsed tooth, we'll get there in a second, you need to do a root canal afterwards. So what we do in our practice as veterinary dentists is we would take the nerve out on the first day and temporarily medicate it like I did with the pathologic fracture, and then do the splint. 6 weeks later, they come back, take the splint off, do the root canal. In your practice, if you want to do this on an emergent basis for the client, and the client understands the need to go back to the veterinary dentist in the future, because in some places you can't get into the veterinary dentist for a while or they may not be willing to drive, it's totally fine. Do the acrylic splint, okay? Get the animal stable, get the animal healthy, and then send it to this veterinary dentist in the future. In 6 weeks, they can take the splint off and do the root canal at that time. As far as tooth avulsion, if it's 99% of the time, tooth avulsions happen because of gum disease. They did. It's really rare to see an avulsion in a patient. And so really, honestly, in this day and age especially, I cannot remember, I'll be honest, the last time I replaced an avulsion tooth. And especially with COVID, I wouldn't even be thinking about it. I would just get them under anesthesia as soon as the dog's stable, take an x-ray to make sure there's no root remnant, and just close the defect. Okay, I'm going to go back and just do some quick questions here. Let's see, those are the ones I've answered. Dr. Stewart said, had a great point. When you have done jaw fractures, the biggest challenge that we have with jaw fractures is getting the occlusion right. So always make sure that you check the occlusion prior to waking that patient up. Extubating the patient's a good idea. Some people do pharyngostomy intubation. I don't. Cold laser. Jackie asked about cold laser. Sure. I mean, I don't have a lot of experience with it, but there's absolutely no reason why you couldn't, and I think there is some study. Let's see. Soft muscle comment. Yeah, well, sometimes, especially in puppies, a soft muzzle can be all that you need to do. But in general, it's adjective or additive, you know, adjunct, sorry, is the word I'm looking for, and temporary. But, you know, again, we're talking about clients not having money. Oh, cats. Oh, yeah, cats are a challenge. I don't generally do muzzles in cats. You know, that one, there are some tape muzzle type stuff that it is other than that. And then Gary, if they want to fix an avulsed tooth, actually milk. Milk is the best thing to put an avulsed tooth in when you want to try and save it on down the line. All right, moving on. Get rid of that. Fractured teeth. Okay, we're going to see these. We're going to see these quite a bit. Typically, broken teeth are going to be canines or carnassials. Why? Well, canines and incisor due to trauma, right? Which may be less common, maybe because dogs aren't out getting hit by cars. They're not out playing with sticks. I will tell you, we have a client coming in to see us in Santa Barbara on Monday because the client was out back in their backyard practicing their golf swing, and the dog decided they wanted to jump in and grab that ball before he hit it and broke 6 incisors, I think, or something. So it could happen. But where are you going to see more of this? These dogs are bored, man. They're sitting around doing nothing, especially if you've got a young, high energy dog. They're going to chew more, and especially if they're caged for a while, they might break it there. And here's where it's really going to happen. Carnassials are going to break on hard objects. And you know those clients are at home getting driven crazy by their 3-year-old golden retriever that's like, I gotta go, I gotta go, I gotta go. Or their husky or any large breed dog's like, dude, I gotta get out, I gotta go, I gotta go. And you're like, sorry, we can't go out, we're isolated. So here's a bone. Well, and the problem is they give them something that they can chew on. And what you see down below, chew treats must be soft enough to indent with a fingernail. Well, how long is that gonna last? About 30 seconds. And then they're like, well, dude, now what do I do? Well, here's something harder. And then what do? They break a tooth. So I think nowadays we're going to see more broken teeth. I really, really do. Here it is. We've all seen this. This hurts. This hurts bad. Any of you guys have had a deep cavity, you know what this dog's going through. You've got to treat this. In my opinion, this is an emergency treatment. It needs to be treated. This dog is in agony. They're not showing the signs. They never do, right? Our favorite words out of our client's mouth. Well, it doesn't hurt, doc. He's eating, right? Well, if they don't eat, they're going to die. This dog is in pain, and he needs to be treated. He needs to be treated now. How does he need to be treated now? Bottom line is, if you don't treat him at the beginning, first of all, it hurts. And then over time, they're going to die. It is less painful, but these not necrosis teeth, so here we go. That dog is eating, it looked fine, but that's three root canals that are causing infection to this dog every single day. So fractured teeth are pretty easy to diagnose. I mean, look at it, well, there it is. If you're trying to determine whether there's pulp exposure or not, I'm not talking about uncomplicated crown fractures. I mean, yes, it'd be nice to treat, but they're not worth treating at this day and age. Until you're going under anesthesia for the procedure. But basically under anesthesia, once you've got them under, try and find pulp exposure. If there is, then obviously you need to treat it. And dental radiographs are required for dental definitive care. What's your emergency treatment? Okay. Well, if you have a mature patient, this is where we're really going to talk about when do we treat something now versus later, okay? When you talk about treating a patient that is mature, meaning that the tooth is mature, and I'll show you pictures of this in a minute, that means a patient over 11 months of age. What are you going to do emergency-wise? Does this look familiar? Minimum database, right? You want to make sure that animal's healthy. Now, they probably didn't have major trauma, but like that dog that got hit with a golf club, he did. So again, minimum database, ideally in-house. Pain control, right? Duh. NSAIDs if healthy. Gabapentin if liver or kidney issues is what we generally recommend. Now, we talk a lot about, do you treat this tooth? Is this a tooth that needs to be treated with pain medicine now? And for years and years and years, I said, yeah, maybe, maybe not. Yeah, now we're saying we do. We wrote the dental guidelines, and there's enough of us that believe. So this dog, if I saw it, would I treat it? Yeah, absolutely I would. So again, what would I do? I'd run a minimum database, and I'd send them home with pain medication. This is one of the critical points of this lecture, and I want everybody to listen. I know this is a change from what we were taught. This tooth does not need antibiotics. Antibiotics are not going to stop this tooth from dying. It's not going to stop the infection from coming in. It's not going to make that dog feel better. Antibiotics are not indicated in freshly fractured teeth or non-abscessed necrotic teeth. Please do not give antibiotics to either of these patients. They don't need them. It's not good for their tummy. It's not good for anybody. Don't give these animals antibiotics, please. I've said that for many, many years, and I'm repeating it now because I think it's critical. So like I said, for a mature patient, and again, sooner the better, not an emergency. You don't need to be doing a root canal or an extraction on a patient with a fractured tooth. You don't. In 6 months, that dog's still going to take a root canal. You don't want to wait 6 months, but if you have to, you can. It's not going to change. A lot of people talk about doing vital pulp therapies, or this is an old thing that was taught 40 years ago. Oh, do vital pulp therapy. We don't do vital pulp therapies on mature teeth, on teeth that have a complete apex. We do root canals, okay? Why? Even if you get to that tooth within 48 hours, according to Dr. Clark's study, you have an 88% success rate. That's meh at best. Root canals are closer to 99. They do really well. So I'm not going to take that. Number two, my study from 20 years ago, every tooth that was fractured, okay, that we did a vital pulp therapy on, eventually failed. Every single one that we did eventually failed. If we did it for a fracture, if it was cut off for a crown amputation problem for an orthodontic issue, that was totally fine. We did vital pulp therapy and it worked every time. So I don't do vital pulp therapy in a mature tooth. No matter if it happened in the parking lot, I'm still going to do a root canal. Other options, extraction. Obviously, extraction is an option for any tooth, but it's not this preferred for strategic teeth. Oh, I see, I missed a in parentheses there. I'm sure Kim's not very happy with me right now. But why do we like doing root canals? Well, it maintains the jaw strength. It maintains the tooth structure. Much less painful in extraction, especially canines and carnassials, especially mandibular canines. I really like it. What I tell clients is the dog feels better walking out than they do walking in if we do a root canal. If we do an extraction, we hurt them and then they feel better. It's still better than not treating it, but bottom line is that we'd rather do a root canal. And then honestly, we have much less complications with a root canal than an extraction. I mean, these are the kind of things, these are huge teeth. We don't want to take them out if we can avoid it. You can break the mandible, especially in the lower canine area and that lower incisor, lower molar area. That looks fun, doesn't it? That nice hook there. I'd much rather do a root canal than extract that tooth right there. And these are the kind of things that we see post-operatively for taking out these canines. This poor dog on the left had just chronic osteomyelitis from the extraction, and then you've got that huge oral nasal fistula. Pathologic fractures can happen when you're extracting teeth. Retained roots, we see these all the time, and that you would think that people would know they didn't get that whole canine out, but You know, we see it not infrequently, and then something we're seeing more and more thanks to ankylosis is roots forced into the mandibular canal. Please, that's where that arrow is pointing to. Please don't ever go after a root blind. If you break a root, if you're doing an extraction and you break a root, it happens to me every day. It does. It happens to the best of us. If you break a root, do a cursing dance. It helps. It really does. Okay, pick whatever word you want. Okay, blame your tech. That's a good thing too. And then don't go after it blind. Don't ever go down the rabbit hole. All you're going to do is push it into bad places. When you break a root, and it's going to happen, do the cursing dance, make a flap, drill some bone away, do an open surgical extraction, find the root, identify the periodontal ligament, and elevate it out with small sharp elevators. Okay? So for small teeth, you know, incisors, premolars, sure, take them out. Some clients want to fix them, some don't. Especially in this day and age, more clients are going to be money conscious. Dude, totally pull those incisors. You know, they don't need them. So where does a fractured tooth truly become an emergent situation? In a young dog. And again, young dogs are going to be more active, more crazy, more chewy, especially if they're being cage trained, right? So they break a tooth. So there's an immature tooth. So these are dogs under about 11 months of age. Okay? They have not completed their apex yet. They don't have a complete root yet. So when you see them, if the client wants to save the tooth, and then we're going to talk about what we need to do. But if you see this dog, it's just like doing an adult dog at the beginning, okay? They should be treated with pain medication, do a minimum database, do a full physical exam. Then you have to have a discussion with the client. Do you want to save the tooth or not? If the client is interested in salvage, this is one that needs to get to the dentist now. This client needs to be treated emergency, like within the first couple days, if at all possible. Why? Here's what it looks like when you don't have a complete apex. On the far right, this tooth has not completely matured, so you cannot do a root canal on it. So if the client is really interested, and I'll get to that in a minute, they should be presented, again, pain management. Antibiotics aren't going to help. Stop. Nope, nope. I know you're all thinking, antibiotics, yes. Nope, nope, nope. No antibiotics, pain management, anti-inflammatories especially. Get that patient to a veterinary dentist and we'll do a vital pulp therapy. I already talked about this, but if you do a vital pulp therapy, the problem is even if you get to it within 48 hours, it only has an 88% long-term success rate, and that's lower in my experience. So you've got to do annual radiographic monitoring, which compliance is low in your clients, as you well know. So what most veterinary dentists are going to do is they're going to do a vital pulp therapy. So here it is. Here's a picture of a vital pulp therapy with the 3 different layers of medication. But then what they're going to do is a root canal. So if a immature tooth is going to be saved, you need to do vital pulp therapy today and a root canal in 6 months. If your client balks at that, pull the tooth. Okay, you can send it to the dentist to be pulled, or you can just pull it, get it out. If the client's not willing to do that, why do I say that? Because people do vital pulp therapies on it, and here you go, 9 years later. You can see how well those vital pulp therapy worked. There was no clinical signs in this case. This was part of the study. 9 years. The only reason the client came in is because we sent him a postcard, say, please come in. We will do a free recheck under anesthesia. Look at how much infection this dog's been in forever. You've got to take care of these patients. Please do not allow vital pulp therapies to continue. In my experience, they just don't work. And again, if clients want to get it taken care of in one step, you know, especially with finances, not wanting to travel, blah, 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 you know, extraction is the best course you can do that for anything. I'm going to pop up here to questions real quick again. I already answered those. Let's see. I don't know my dose of gabapentin, sorry, off the top of my head. Thomas, I'm not sure which bonding the tooth right away, type me again, bonding which tooth. If you're talking about a complicated crown fracture that the root canal is exposed, no, absolutely, positively, no. You cannot do a bonding if you have direct pulp exposure. It either needs to be extracted or root canal unless it's a young dog. Would you give antibiotics in a complicated crown fracture that does not have an abscess? But no, nope, I don't. I don't ever give antibiotics. Bottom line is the answer is always no, unless it's abscess, which we're going to get here in a second. No, I don't use, I do not believe in antibiotics for periodontal disease. That's been around for a long, long, long time. Okay, so because people haven't been getting their animals' teeth treated, they're going to see more abscesses. So when you see an abscess face, when these things blow up on these guys, you can see on the right side the pus coming out of his eye, the angioedema down his neck. On the left side, one important point about that abscess, that tooth is not directly pulp exposed. And I want you guys all to remember this. You don't have to have direct pulp exposure to have an abscess tooth. Teeth can abscess from indirect pulp exposure, and that's that uncomplicated crown fracture. So and I've heard from veterinarians in the past, oh, it's not complicated, so it can't be the tooth. Yeah, it can. It certainly can. So when you see an abscess tooth, go for me. Okay. So what this is it's an acute exacerbation of a chronic problem. That tooth has been infected for months to years usually. So these dogs have been dealing with it for years, and it's just what's called a phoenix abscess, an acute on chronic. Here's the thing. You don't have to do anything, and that abscess is going to resolve. It's just basically you have this chronic infection, the periapical lucency, the chronic disease, and then the body, for whatever reason, the immune system goes down and it blows up. Honestly, it's going to go away even if you don't treat it. For the most part, it's going to go up and down and up and down and up and down, wax and wane. But you do need to treat it. You're going to make the dog feel better sooner. But this is the important point, and I'm going to say this a couple times. It is not resolved without proper therapy. We'll get to that in a minute. So when you see a dog with an abscess tooth, first of all, take a quick look to make sure that there's nothing else going on. Again, shocking. Minimum database. Yes, please work these patients up. Make sure they're healthy. Again, pain medications, NSAIDs are really important. Here we go. Yay, everyone's going to be excited. Yes, you can give these animals antibiotics. Yes. You don't have to. It's going to get better without them. Okay. But please, and if you guys have questions, put them in the question thing, because I can't see the raised hands. Don't raise your hand. Ask me the question. I'll come back to it later. So this is one that you can give antibiotics to because it is going to make them feel better. It's going to make it better faster. I know you guys may have heard, and I know this isn't emergent care, but it's important for me as a veterinary dentist to say, I know a lot of veterinarians and a lot of veterinary dentists will say abscess teeth can't be root canaled. BS. I do it all the time. They do great. As long as the root is healthy and as long as the abscess isn't massive, they do really, really well. So you can, and again, I'm not going to tell any of you guys in general practice that extracting these abscess teeth is bad. Absolutely not. But if the client's interested in salvage, why not? Don't just say it cannot be fixed. It can in a lot of cases. We won't know until they have the pet under anesthesia. I will tell you, most dog abscesses that you can treat. Most cat abscesses, you can't. And again, like I said, extraction. Here's a really important point though, guys. When you see these abscess teeth, and I do that, and this has nothing to do with COVID. This has everything to do with clients, plain and simple. What's going to happen is you're going to see this patient on Saturday afternoon, and you're going to say, yep, it's got an abscess tooth. It needs to be treated. I'm going to put you on antibiotics. I'm going to put you on pain medication. And we're going to get you scheduled in next week for the surgery, or we'll send you to the dentist for next week for the surgery. And, here's some pain meds, antibiotics, make them feel better. 95% of these clients are going to cancel that surgery appointment. Why? Because he's better. The swelling went away. This is why it's really important for you guys to have a real conversation with your clients today while they're in the office. This is going to go away. The swelling is going to go away with these antibiotics, but it's not fixed until we take care of the tooth. And your dog's going to still be in pain and still be infected. And you've got to hit them hard with that before you let them out of your practice. Okay? So don't let them cancel. So here, just a quick example. On the left is pre-op, right is 6-month recheck. You can see all that bone grew back in. The periapical lucency on the left is outlined by the red arrows. And on the right, you can see all that bone grew back in. It did just fine. So don't tell your clients it can't be fixed. But this obviously is an extraction candidate. It's not going to do very well. I can't even fix that one. Another really important point, if you don't have dental x-rays, you probably shouldn't be treating these patients. Why? Just because everything looks absolutely classic does not mean that that tooth is the cause of the thing, is the cause of the infection. And here's just one example. Here's a poor dog. This dog's had on and off infections for about 9 months. 6 months ago, he had his upper fourth premolar extracted because it was broken, and it was the cause of the abscess. And then eventually they made their way to me, and I got them under anesthesia. And the vet did a great job taking out that upper fourth premolar. See that there's no roots left behind. Everything looks great. So yeah, they fixed it. But look at the upper first molar. Look at the huge periapical lucency around that upper first. I don't know whether that upper fourth was a problem in the first place. It was. They said it was broken, which I'll believe them. But the problem was the upper first. So you've got to take dental x-rays to make sure that you're dealing with the right tooth. All right, before I move on, I already answered that question. So Jared said 7.5 to 10 mg per kg. I think that's twice a day for gabapentin. What material do I use for vital pulp therapy? I use mineral trioxide aggregate as the base. And then on top of that, I use glass ionomer, and on the top, a composite restoration. If the dog has a fractured canine that has a root canal, that had a root canal, is it painful? No. If the dog has had a root canal, the nerve is gone, and even if he re-breaks the tooth, it just needs a filling. Does a patient, Danielson, excellent question. Does the patient have to have facial swelling to cause an abscess tooth? You might have read some of my newsletters in the past. The answer is yes. You know, when you see that periapical lucency, let me go back to this. This is a kind of an esoteric thing, but what the heck, I can be esoteric sometimes. So you see the periapical lucency around that, those red, the red arrows pointing at that first molar. Everyone wants to call that an abscess. It's not an abscess. It's a periapical lucency, which is typically, in a dog, a granuloma. So it's a chronic inflammatory change. It's not an abscess. It can be a cyst as well. People often will get cysts, but this is a periapical granuloma. It's not an abscess. It could be, but it's rare. You'd have to have histopathology to make sure that it's actually abscess. So I understand why you're going to tell your client that he's got an abscess tooth. Because if you say your client, hey, he's got an abscess tooth, they're going to let you treat it. If you say, well, your dog's got a periapical granuloma, they're going to be like, oh, why do I need to treat that, doc? But they understand why an abscess tooth needs to be treated. All right, caudal stomatitis. This sucks. This is one of my least, well, okay, let me be honest. I hate this disease. I'm sure all of you do as well. The main reason is it's because it's the one disease that I can't look at a client and say, I'm going to be able to fix it or not. You know, if you bring me a cat with a huge tumor, which we'll get to in a minute, I'm not going to look at the client and go, I can't fix it, sorry. Or I can. Stomatitis is one of those things you do everything right and it still doesn't work. Cats are cats. So I want to explain a couple things. What you guys are seeing in this is that inflammation in the back of the mouth where the jaws hinge together, okay? If you have inflammation, I got to put my wine down, dang it. When you see inflammation where the jaws hinge together, that's caudal stomatitis. That inflammation back there is caudal stomatitis. Anything else is periodontal disease. So we call it caudal stomatitis because it's the area in the back of the mouth. Stomatitis is just inflammation. You burn your cheek on a hot meal, you're going to have stomatitis. So caudal inflammation is that. What do you see? I'm hoping all of you guys know this. Halitosis, not eating, pawing at the mouth, anorexia, crying out, weight loss. The cat's miserable. He's not taking care of himself. He's drooling. He's got pus. We all know what these cats look like. What do you see? Well, hopefully most of you guys understand that it's all really nastily inflamed tissue. But the big thing is, look in the back of the mouth. In the back of the mouth like that, even though you see everything looks good in this cat in the front, that caudal area, or the area in the back of the mouth, I don't biopsy these anymore. I don't run any other test. If bilaterally those things are inflamed, that cat's got stomatitis that needs to be treated. This is, and I'll talk about this at the very end of the lecture, I'll repeat this, incredibly rare for animals to stop eating because of their mouth. Plain and simple. They almost will never stop eating because of their mouth. So we'll talk about that. This is the exception to that rule. These cats will stop eating because of their painful mouth. All right, so how do you treat caudal stomatitis? What's the first thing? Well, some of these cats, unfortunately, have probably been treated with steroids for a while and delayed the surgical therapy. So you're getting this acute issue now. So ideally, avoiding the problem would have been to talk to the clients about doing extractions earlier. So what are you going to do when this cat presents to you with caudal stomatitis? Shocking. Run a minimum database, ideally in-house, because you really need to look at the whether they're diabetic, especially if they've been on steroids for a while, and how are their kidneys, blah, blah, blah. If you need to treat a patient, make them feel better, steroids are the best. I mean, steroids are going to knock it down for the most part. if it's non-diabetic. And most of your cats are going to be non-diabetic. So usually I'm really conservative with my steroids. I don't like them. I was raised when I went to vet school in the late 80s, early 90s. Steroids were evil, so we didn't use them very much. So we're trying to be pretty conservative, 5 to 10 mg per kg. If the cat's diabetic, NSAIDs, as long as their kidneys are functioning normally, NSAIDs will help them for a little bit as well. But generally in this day and age, you're going to give these cats a dose of steroids to make them feel better. If the steroids don't work, I'll be honest, the cat's in trouble. If you give a cat a shot of steroids and it doesn't knock it down, either one, your diagnosis is wrong and think about cancer, or number two, you're going to tell the client that extractions probably won't work. What would you do? Well, soft food would be for either one, cyproheptadine plus or minus a feeding tube, and then pain management, buprenorphine and gabapentin. And I'll tell you, if steroids don't work for a cat, you're in trouble. Definitive care for stomatitis, Brooks' opinion, most veterinary dentist opinions, extractions. A lot of veterinary dentists will just do the premolars and molars. I'll be totally honest, I do full mouth extractions. I don't even think about it. If there's no inflammation to the canines and incisors, and I mean none, I'll let the client maybe keep them. But honestly and truthfully, our success rate is so much higher with full mouth extractions. So this is back in the day when I was afraid to take both lower canines out at one time. So I would leave one lower and one upper canine to avoid lip catching. And you can see that cat had horrible stomatitis, 100% healed. Okay. Let me go back and take some questions. I'm sure there's a lot. There's always a lot on stomatitis. Let's see. Immune modulatory dose of azithromycin. Yeah, I don't. I'm not a big believer in drugs. I am a surgeon at heart. I'm a dentist, but I'm a surgeon at heart. I don't generally use any type of anti-inflammatory agents. If stomatitis treatment doesn't work, this is a whole long story we can talk about in the future. I will use cyclosporin. That's my drug of choice for resistant cases. Do I do an FELVF IV test on caudal stomatitis? Honestly, I mean, it's not a bad idea. It's not going to change the way I'm going to treat the patient, though. It doesn't. I mean, I think that FELV, FIV cats get stomatitis worse, but I don't think they get it anymore, and I don't think that it really changes things. How about antibiotics post-op with dental disease? No, antibiotics are not indicated. I can have a whole lecture on doing antibiotics. The only time I use antibiotics is a patient that is compromised, heart murmur, diabetes, kidney, FELV, FIV, for example. I will give one dose intraoperatively. I could talk for hours about antibiotic usage. The answer is no. Vibragen, the feline interferon, honestly, I think it's a different thing. Somebody asked about using feline interferon. I don't use feline interferon. I've used it in my cases. Now, if you're in Europe, and here's an interesting thing. Here's a really interesting thing. In Europe, feline interferon tends to work pretty well. In America, it doesn't. I think it's a different disease. I really do, and I think it's multiple different diseases. So I don't really use. I mean, feline interferon is safe, but I don't think it works very well. And someone had asked about azithromycin. I've tried it. I haven't really done it. I don't think it works very well. Will I start steroids prior to full mouth extractions to keep? I will if the cat's miserable. If the cat's got stomatitis and he's still eating and he's relatively happy, will I give steroids? No. Steroids delay wound healing a little bit. I try and avoid them. If the cat's miserable, I will give them steroids to get them until we can do surgery. And then I'll usually wait a month till it's kind of going down a little bit. But in general, I will do. I won't use steroids if I can avoid that. Cynthia, your question on oral steroids versus injectable. I'll be honest, I have had lousy success with oral steroids in cats with stomatitis. I don't know why. I'll be honest, it's probably because it's just not getting into the cat. I mean, pilling cats is miserable in the first place. Then you add a cat whose mouth is horrifically painful. I generally don't. You can, it's fine. Do I close the gingiva and a tooth root abscess? Absolutely, every single time. There is absolutely no indication for leaving an extraction site open. That is old information. Do I use CO2 laser? No, I don't believe in it. There's no studies, in my opinion, that show that it helps. Do I do Bartonella testing? No. The studies have shown that they all have Bartonella. So I have treated these animals. In Brooks' opinion, it doesn't do anything. And the question about the only time that you would have an infective endocarditis would be if you have a heart murmur. So if you have a heart murmur, you might develop endocarditis. And oh, by the way, studies have shown that doing a dentistry does not increase the risk of endocarditis. It's letting that infection stay. So I would use antibiotics with the abscess to make the animal feel better. But again, I cannot remember the last time I gave antibiotics to a patient under anesthesia that wasn't really sick, and I've never seen it. All of that endocarditis is way old. It's all been disproven. So no, antibiotics are not indicated. And these are the questions I get all the time during my lecture. Antibiotics, antibiotics, antibiotics. Yeah, no, we don't use antibiotics. Okay, moving on to oral masses. I want to make sure we get through everything tonight. There's a lot of really good questions. I got a few more things that are really cool to kind of go through. Oral masses, they're kind of a big thing. We're seeing it more and more. And again, why are we going to see these oral masses so big? Why are they going to be such an issue in our patients? Because they're not coming in for care. They're not doing our clients are not coming in and doing their regular exams. They are waiting, and again, we understand social distancing. So the problem is, instead of actually treating these patients when we should be, now we're getting it later on. But this isn't just a COVID situation. This is very common for us to see these patients on a regular basis that have these huge masses that the clients are like, dude, it was there. It wasn't there yesterday. Why is that the case? Well, number one, how many clients look in their patient's mouth? I mean, never. So by the time they can actually see something, it's massive. And then two, why does it? Well, number one, these things grow exponentially. Okay, oral mass, well, all masses grow exponentially. So the time it takes to go from this big to this big is the time it takes to go from this big to this big and then this big to that big. So the issue is that you have this little 1 centimeter tumor that is now 2 centimeters, and then in a month goes to 4 centimeters. Well, now you've gone from little to big. So they do grow exponentially. The other reason that you'll see these guys getting really, really big tumors, and the client's like, doc, it wasn't there. It was, but we didn't see about it. But the thing is that the infection, what'll happen a lot of times, these animals, they'll get this slow growing tumor, and then they'll bite on it, they'll get it infected, or it will outgrow its blood supply. So when it outgrows its blood supply, it becomes necrotic, and then that infection goes, and it gets this really big secondary infection. So that's why you're going to see it. But it just, honestly and truthfully, I mean, nowadays, I think more clients are looking at it, and quick aside, I know that you guys that are out there, have you noticed how needy our clients are now? Oh my Lord. I know that you guys are all putting up with this now. Give them a break. We're all stressed. They're sitting at home watching their dog. They're just watching their dog 24/7. And they just, I give you a little quick aside. We call them, here's a little funny, we call them butt puckerers. And the reason that we do that is we had a client about 10 years ago, well, maybe more, 20 years ago, I'm getting old. And the client called my technician on an emergency, because we had an emergency line, called my technician the night after surgery and asked, my dog's butt is puckering and unpuckering a lot. Is that normal? And she's just like, dude, stop looking at your dog's butt, please. But we call them butt puckers because they're doing that. Why? Because honestly, they're sitting at home looking at their dog 24/7. And two, the clients that are coming in, honestly, are a little bit, into their dog a lot of times. So give them a little bit of a break. Expect that. Don't get too frustrated. Just know that, you still have a job, which is really, really nice. So going back into the oral masses type stuff, what are you going to see? Well, this is the problem, is we typically see it when it's really big. And there's really not a lot that we're going to be able to do to fix that. And this isn't just a COVID thing. It's an everything thing. It's one of those things that we just see because clients don't do an exam on a regular basis. And especially if they're not coming in for oral exams or their routine dentistries, right? So they're not coming in. And these are the type of things that don't get treated. And same thing here. You got a facial swelling on this poor dog's face, huge oral mass in this other dog here. And these are the type of things that you're going to start seeing in there. Don't forget about cats. And I'm just going to throw this out here really quick as far as cats are concerned. Squamous cell carcinoma is by far the #1 tumor in the mouth of a cat. It can be productive, like the cat on the right with the sublingual squamous cell carcinoma, or it can be destructive. So on the left, what you're seeing is a cat with a huge opening there. This cat had extractions done about 5 weeks ago at its regular veterinarian because the teeth were loose, right? Well, the most common cause for loose teeth in an animal is periodontal disease, right? And so they had periodontal disease and they plucked it out. They didn't take dental x-rays and it didn't heal. Ooh, then they tried to close it. It didn't heal. Why didn't it heal? Because that's cancer. So when you see, and this is a really good picture to show it, look at the canine. See any gum disease there? It's beautiful. When you're doing, this isn't an emergency thing, I'm going a little bit on a tangent, but you know what? Hey, I do that. When you see a cat that has really bad disease in one area and the rest of the mouth looks good, especially an older cat, think cancer. Cancer is going to be the big thing. So this poor cat had cancer. It can be destructive or it can be productive. So don't forget about that. So what are you going to see? Well, anorexia sometimes. Usually animals will eat right through any oral pain or anything like that, but I mean, it could get so big it could stop them from eating. Bleeding from the mouth, if they bite on it or if it gets infected, it's gonna bleed. Purulent discharge, okay, you're gonna see that. It may smell. When these masses die, it may smell. And then you'll see it. I mean, that's the big thing. So is this looking familiar yet? What are you gonna do today? You're going to run a minimum database. You're going to get that patient on pain medications. Now, this is again, if you've got pus coming out, if it obviously looks infected, sure, put them on some antibiotics. If it looks like that or that, no, I'm not going to put them on antibiotics. That's just a tumor. It's not going to help. I know we all want to use antibiotics in the mouth. Stop, please. But this is not going to help, plain and simple. It's not an abscess. Now, you may think that that dog on the left there is an abscess, but what can we do? What can we do, Dr. Niemiec? Well, we need to get an answer. And yes, you know, we're in a COVID situation and all that kind of stuff. But we need to make the dog feel better and we need an answer because people hear cancer all the time and they're like, oh, my dog's going to die. I can't fix it. I mean, the big C word, right? Oral cancer is actually really treatable. Depending on when you catch it and where it is and what it is. So cancer is not a death sentence anymore. You just have to have a committed client. So what are we going to do now? What are you guys going to do? Or what are you going to send it for? Well, the initial care would be to debulk it, to cut it back, to make that dog more comfortable. At that same time, get a biopsy. Because I'm telling you, these patients that are presenting to you with oral masses, they ain't presenting to you with a little tiny growth. They're presenting to you with these things hanging out of their mouth, which you'll see in a second. So you need to make the patient feel better, and you need to get an answer so we can decide about definitive care. If it really is that bad, considering an E-tube may not be a bad idea to feed him, but honestly, if that tumor is that bad, we're probably not going to be able to fix it. So probably not going to be something you can do. So here we go. This is a dog named Luna. And this, honestly, I saw the consult. My resident did the surgery. This popped up overnight, right? We hear it not infrequently. They're like, it was fine a couple days ago, but not today. So I saw this dog on a consultation, and you can see the necrosis of this mass. You can see how huge it is, and he's basically, you know, growing a whole nother dog there. So obviously this dog is not eating. Obviously he's painful. Obviously he's biting into it. Obviously he's miserable. So again, this is something that we needed to treat. So Dr. Holloway went ahead and got him under anesthesia and took dental x-rays. And you can see the canines already come out. You get all these teeth being luxated. You can see all this bone loss. So obviously this is a malignant tumor. I'm 99% sure it ended up being a fibrosarcoma. I don't know off the top of my head, but that's a nasty tumor. There is treatment options. We'll get to that in a minute. But you know, today, what do we want to do? We want to make the animal comfortable, right? That's our job. And we want to also get an answer for the client. So what did she do? Well, she cut it back. That looks pretty darn good now, huh? That's a whole new dog that we made in about 45 minutes of surgery. And again, general practitioners that are really into veterinary dentistry, you could do this. Does this bleed a lot? Oh yeah, it bleeds a lot. Is it a fun surgery? No, not really. Does it take a little bit of expertise? Ideally, but this is 15 minutes post-op. Look at how great she looks. This is a whole new dog, and even if this client doesn't pursue advanced care, whether it's a mandibulectomy or if it's radiation therapy, depending on the type of tumor, he's got a few months of really good quality life now that we've given him. There's nothing wrong with that. This is a whole happy dog. We've got an answer. The client can make informed decisions. It's a really good thing to do for these patients. Definitive care, well, in general, chance to cut's a chance to cure. Most tumors, squamous cell carcinomas, fibrosarcomas, acanthomatous ameloblastomas, they do really well with surgery. If it's a really big tumor, radiation therapy, if the client doesn't want to go through that, way too much detail to go into. But in generally, surgery is curative in dogs. Cats just don't do well. I'm sorry if you want any good news about cats and squames, they just don't. There's one study on doing radiation and chemo at the same time. I just don't think it works very well. But I want to throw this in, and yes, I know this is an emergency lecture, and I know we're not talking about definitive stuff. But again, cancer is incredibly curative. So this is an acanthomatous ameloblastoma. This is a dog that came in to see me several years ago, had a big tumor, and went all the way back to the back of the canines. It doesn't look bad on this x-ray, but the dental x-rays, it went all the way back to about P1. So it had taken all that bone away. So unfortunately, it took a big surgery. So I did a big surgery. I did a rostral mandibulectomy, bilateral, back to P2. So you can see how much of this dog's jaw that he lost. It was a big surgery. Cured it, 100%, gone, cured it. Here he is 2 weeks later. Think he cares? He's playing ball. He drools. Really? That's the worst thing in the world? I'd rather have this done than an amputation of a leg. Yet we do that not infrequently, even with osteosarc. I put these in here so you guys can talk to your clients about the fact that oral cancer is curative, especially acanthomatous ameloblastomas. They do really well. But even squamous cell carcinomas and fibrosarcomas in dogs, they do really well with surgery. If they can't have surgery, if it's too big or the client doesn't want to do it, the squams and fibros in dogs respond pretty darn well to radiation. They get about a year of quality growth or quality life. So melanomas are the big baddie. They still can be fixed, but please don't allow your clients to think that oral cancer is a death sentence, especially if it's rostral, especially if it's forward in the mouth. So I'll go back to some questions here. I already answered the question about antibiotics. Do I think magic mouthwash will help for stomatitis? Yeah, I think we're going to talk about it. Lauren, you're up on the game here. Most people don't know about magic mouthwash. Yes, I do think it will help. I don't think it'll help a lot, but I think it will definitely help. We'll talk about magic mouthwash in a little bit here in a minute. Do I have any luck with doxycycline in refractory stomatitis cases? No, I really don't. I mean, you can read about so much stuff online, eye of newt, tail of toad, all that kind of stuff. I honestly haven't had any success with anything in refractory cases except for cyclosporin. But honestly, cyclosporin fixes 95% of them. It really does. Most of them don't need anything. Is Convenia effective for abscess teeth? Well, I mean, it does have a dental label. It has a dental label in Europe. It's not my favorite antibiotic, I'll be honest. But the benefit of Convenia, especially in cats, is it's in the cat. Just kind of like with the steroids we talked about. In the cat is important. So the fact that it's in the cat, I think it does work, and it does help. It will knock the infection down for the most part. What do I recommend for palliative care for oral melanoma? Not much. Small bags of dog food, unfortunately. Melanoma is a baddie. Melanoma just is going to spread. It's going to cause lots of things. If they're not going to do anything else, you can certainly do, you can debulk it, make them feel better. But that's a better question for an oncologist. I know they talk about DHEA and things like that, but that's not my area. I'm a surgeon. Anything like that needs to be treated by somebody else. Wouldn't it be better to do an incisional biopsy first? Yes, and that's why in that, and generally we just do an incisional biopsy. But with that dog, we needed to make him feel better too. I mean, if we didn't cut back most of that tumor and we didn't take away any normal tissue, we didn't negatively affect our ability to close that on down the line. So I mean, you could do an incisional biopsy, but then the problem is if you do an incisional biopsy, you haven't made that dog feel better, and now you've made him suffer for a week or two before you get that biopsy back. And so now we didn't really hurt that patient very well. She did really well. We just cut that nasty tissue out and made him feel better. And who knows? The client may not elect to do anything more. And I don't know that client is going to allow to do a mandibulectomy. Are bony masses common in cats? No, not really. Dogs do get osteosarcoma, but I'll be honest. I've seen maybe 2 cases of osteosarcoma in dogs. We don't see them incredibly often. Now, the most common, by far, the most common tumor in a cat is squamous cell carcinoma. Fibrosarcoma is a distant second, but you will see that. You'll see the bony invasion secondarily. Let's see, is this something? How do you achieve hemostasis on that mandibulectomy? That's a challenge. What we do, basically have a lot of gel foam or vet spawn available and have a cautery stick. But what we will do is make a little window over the mandibular canal. With our burr, we'll make a flap and we'll go in there and we'll ligate the mandibular artery before we cut it off. It's a challenge, but bone wax can help as well. Oh, good question, Simon. Are intrinsically stained teeth a painful ER situation? Good question. I wish I had an answer for you. I know that while they are dying, while the teeth are dying, they are painful. And that should be treated. Once they're dead, a lot of the pain goes away. I don't tend to treat these patients with pain meds. This would be the one thing that I would just treat the tooth, whether it's an extraction or root canal. I do think it should be treated sooner than later. I absolutely do think that they should be treated sooner than later. But that's what I would do from there. Okay. So moving along here to, we have just a few more things to talk about. I'll probably be done about 6:30 with the actual lecture, and I'll have some time for questions, and I can maybe finish my wine. So caustic burns. We might see them more. We don't see them a lot. ER vets see them occasionally, but I have a feeling we're going to see these caustic burns more often. Why? Dude, what is everybody doing 24/7? Washing, spraying. I mean, you can't even bring food into your house without washing it off with something. And so clients have bought all this disinfectant, but they have no idea what the heck it is. So they haven't used it before. It's not the stuff that goes, why? Oh, we got to get the best stuff. We got to use bleach. We got to use this. We got to use that. So they're bringing in all of these products that they may not know what it is, and they may not know how bad it is for their patient, how dangerous. I'm sure that there's a lot of human hospitals are dealing with kids with this as well. So clients are probably bringing products into their house that they don't know what it's going to do to them or to their pets. So cats, I mean, as we know, they might go up and lick something, but honestly, if you spray your counter with something and then the cat walks on it and then they groom themselves, they're going to get exposed by direct licking or by self-grooming. Dogs, especially small breed dog or large breed dogs and puppies, might drink something. They may lick something, right? They put stuff in their mouth. You might wash something here's the thing, and I heard about this from a friend of mine. A client brought their food home. They had been to the store, and of course they can't bring it into their house unless it's been sterilized. So they put I can't remember what the quaternary ammonia thing, I think, on it to treat I think it was chicken. And they put it on it and they put it on the sink. And what did the dog do? They went and ate it. And not only did they get sick from that, they got caustic burns in their mouth. So I do think that caustic burns are something that we are going to see more in this day and age. And it's something that you need to know about because there's some really important things that you could really mess up if you treat them incorrectly. So this is one of the more important things that I think you guys need to know about. So history, clinical signs. You may have a history of exposure. The client might say, yeah, my dog licked this, or we used this new product, or we brought it in. You may, which would be great. What are you going to see when the patient comes in? Well, drooling's the big one. They're going to be painful. They're going to be drooling. Some of that drool may have blood tinge in it. The patient may or may not be anorectic. I will tell you that caustic burns, in my experience, are an emergent situation. They're coming in now. It's not to be a situation like, well, he didn't eat tonight. In mild cases, it may be that. Pain, right? And what are you going to see? What's your thing that you're typically going to see with this? Are ulcerated lesions in the mouth. These are classic caustic burns. The one on the left there is battery. A dog chewed on a battery. On the right there, I can't remember exactly what it was, but it was some kind of cleaning solution that caused this burn in this poor dog. And it was everywhere. I mean, you can see it there, but it's the entire mouth. That's a young puppy. I think that dog is about, on the right there, I think that dog's about 10 months old, or 11 months old, young dog, and really, really painful. The whole mouth looked like that. So important thing, full oral exam, full body exam, because these caustic products are wicked, and they can cause lots of things, especially if the animal has ingested it. If the animal has actually ingested some, you can look at respiratory compromise, you can look at vomiting, they may be in shock. So these animals can actually be, or, and this is a critical thing, folks, may get really, really sick. So this is a patient that really should be monitored really carefully if you're seeing this. So what is your initial care? Here's a critical point. Do not induce vomiting. If that patient has swallowed it, it's caused trauma in the mouth, it's caused trauma in the esophagus. Once it gets into the stomach, it starts being neutralized, and the stomach, as you know, has got a lot of acid in it. It's pretty tough. If you make them vomit, they're going to re-irritate everything. So number one, here's a critical thing. This is malpractice to induce vomiting. Number two, don't give neutralizing acids or bases. Whatever you do, if you've got an acid thing, don't give them a base. Oh, it's going to make it better. No, it's not. Because what it's going to do is it's going to change things, and it's going to have an exothermic reaction, and it's going to be an issue. So bottom line is, don't induce vomiting. These are the critical points of this. Don't induce vomiting. Don't give neutralizing acids or bases. What are you going to do? Do a minimum database, please, because number one, you're going to be giving this animal drugs, and number two, it may change things as well. Pain management, shocking, I know. Corticosteroids will decrease the amount of inflammation that he has. And this is one of the rare times I'm actually going to use corticosteroids. Now, again, if you give corticosteroids, remember you can't give NSAIDs now, or you shouldn't be. So that's where you're talking about gabapentin or buprenorphine, something like that. The best thing to do, the solution to pollution is dilution, right? Rinse, 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 rinse. The best thing by far is milk. Milk is really good. So if you have some milk, you can use it. Water's fine, saline's fine, but really just rinse it out, get it out of the patient. The better you can do, the best. If it is ingested, again, don't make them vomit. Don't give anything neutralizing, but getting them under anesthesia to dilute the alimentary tract. And again, milk would be the best thing. Make sure, this is in the book, don't do too much though. Dilute it, but if you put too much in the stomach, they can regurgitate, and then again, you're back to that same thing. Supportive care, fluids, because a lot of these drugs are going to have to be given parenterally because they're not going to want to eat and they're not going to get in, and you've diluted it. So injectable drugs are the best. IV fluids are really important because especially if it's been ingested, you want to dilute that systemically as well. So IV fluids, and the miracle mouthwash. Someone asked about that as well. That's in the book. I don't know the dosages off the top of my head, but it really helps. This is a patient that, in my opinion, if it's bad, should be hospitalized and should be monitored because they may develop those shock signs. They may develop other issues down the line. Definitive care, one of the things that you'll see with these caustic burns is that they will, in their esophagus, they will get esophagitis and they can scar. So this is definitely something, this is where I talk about educating your client from the get-go is really important to get these animals taken care of. And so getting them to an internist, esophageal stricture is very common. They may need balloons, they may need stuff like that. So please don't let your clients just go home and not be treated. So I'm gonna, and I guess the last little thingy on that not to forget about is that they can inhale this stuff as well. So chest X-rays are a really good idea. Yeah, so I'm not sure what happened to the questions, so I'm doing my best to answer the questions or repeat the questions first. Justine, how long does it take for a nerve to die off? Absolutely no idea. There's no studies on it. I have seen dogs. I had a dog that I saw, this is many years ago, that I saw for a consultation, and they had a broken tooth that had a fresh fracture, and I recommended care, and the client didn't come back. 3 years later, the client came back. The nerve was still alive. When I did a root canal, the nerve was still alive 3 years later. So the dogs have a tremendous ability for these things to live. So you don't know. Sometimes it takes weeks. Sometimes it takes a long time. If you have Susan asked, if you have a pathologic fracture of 309 or 409, there's no caudal teeth left, how do you use an intraoral splint? Very good question. You can't. Well, you can do, I wrote an article about an edentulous splint many years ago. It's really fancy. In that situation, what I would do is I would do an intraoral wiring, interfragmentary wiring, like I showed you earlier in that picture. Once you have a caudal fracture, which is a challenge, wiring is usually the best way to go. Are you not concerned about gastric ulcers with caustic burns? If so, how concerned are you with steroid use? Gastric, once it's into the mouth, or once it's into the stomach, the stomach is a lot more resistant to that than the mouth or the esophagus is. So they tend to do pretty well. And really what it comes down to is having an internist really manage that, or an ER doc really manage that. But getting that dilutional therapy will really, really help. 1 second here. Sucralfate would be great. Sucralfate would be a wonderful idea as well, as far as taking care of these animals. And I think that would be another really good thing for sucralfate's a great drug. 1 second. Okay. One of the last things I want to touch base on is electrical burn. And again, usually puppies and large breed dogs are going to be the ones that are going to have this as a problem. Again, very similar clinical signs to caustic burns. They may have a history of chewing on an electrical cord, ptyalism, blood-tinged saliva, anorexia, pain, and you'll see charred lesions in the mouth. This is the absolute classic appearance of an electrical burn in a dog's mouth. He's an older dog, but it's one of those things that you're going to see with this kind of charred appearance there. One thing that you definitely need to take into account with electrical burns are respiratory compromise. And please, again, like I told you with your chemical burns, this may happen later. The dog may come in with an acute situation with, you see the electrical burn, you see the charred gingiva, but then that night, the next day, they may develop this pulmonary edema. So definitely monitor this patient. I really think that they should be hospitalized. You can get cardiac arrhythmias as well. And then again, systemic signs, shock, all those things can be seen. Minimum database, again, shocking, I know, but minimum database of pain management. But this one, I would definitely do 3D chest films. This is very indicated to make sure that there's no pulmonary edema. So what is your supportive care? Oxygen. The big concern today, when this dog presents to you, or cat, cats are usually smarter than chewing on an electrical cord, but they can do it. But supportive care, number one is oxygen. Assume that any electrical burn is going to cause pulmonary issues. So it should be assumed before treated. So oxygen would be a great idea, and it should be continued until it's proven that pulmonary edema is not going to happen. If pulmonary edema does happen, furosemide can help knock that out. Again, minimum database is going to help you with your kidney function, bronchodilators, and then for arrhythmias, standard antiarrhythmic agents. Definitive care for electrical burns should not be today. It should not be tomorrow. It's gonna take a while for that tissue to die. It is. And I think one of the issues that we get into, someone had asked earlier about doing not debulking and just getting an incisional biopsy. This is really one where any type of trauma like this is gonna have delayed death of the tissues. So what I would do if the animal's comfortable is I wouldn't do anything for a week. I would put them on pain meds and yes, maybe even antibiotics for that week, and then see what happens on down the line. The other thing is the oral cavity has a tremendous ability to heal. And so don't be conservative with your debridement. So here's just my example. One of my last things I'm going to show you. This is a poor little dog that had electrical burns about 4 months ago. And you can see the scarring of the palate. You can see the bone loss on the x-ray. And you can see that that tooth actually died from the electrical burn and had infection there. So when the dog presented to me, we knew we had to get these teeth out and make the dog feel better. So we took out all the teeth on that arcade behind the P1, debrided the tissue. You can see you have to cut this back to where it's bleeding. When it's bleeding, it's healthy. And so we cut it back to where it's bleeding. We smoothed everything out. We closed it. Here's his 2-week recheck. The dog did great. But again, when you're talking about electrical burns, the big thing is the electrical burn in the mouth is an issue, but it's probably not the biggest thing that this dog's dealing with. Deal with the shock, deal with the arrhythmias, run an EKG on the patient, and then also get chest x-rays and assume that dog's going to get pulmonary edema, and it should be treated until you've proven that he's not going to get it. Okay. So let me go back and answer a few questions here. Yeah, caustic lesions with carafate or sucralfate, great. It will be very, very helpful. Very helpful. Let's see. Do I remove any discolored teeth with cats right away, or I put them on pain meds? Discolored teeth are dead. Pain meds aren't really probably going to help a discolored tooth. I would think that it probably won't. But for discolored teeth, I would say that I would just treat them. I don't know that I would give them pain meds. You know, that's Antonio, it's a great question as far as chest radiographs. If the animal is acting completely normal, if the animal walks in the door and he's got a burn, I think waiting a little bit is not a bad idea. But again, taking them now, taking them later is not a bad idea either. But if the dog's showing any signs of respiratory compromise, or cat especially, I would. And remember, especially in cats, they really hide their respiratory compromise. So you may miss it. So it's never a bad idea. Information's power, what I tell my clients all the time. What type of CT is best? Well, cone beam CTs are wonderful for dentistry. As far as for jaw fractures and masses and things like that, I think standard CT is still better. But for looking for retained roots, looking for abscesses, I generally think that a cone beam CT. Miracle mouthwash, honestly and truthfully, these are usually emergency people. It's in my book. I'd have to look it up, but I know it's lidocaine and a few other things. I don't sure off the top of my head, but I'll put it in an email for all you guys so you can have it later on. I'm sorry, I'm not sure what it is off the top of my head, because honestly, I don't deal with these patients very often. I deal with them after the ER vet has taken care of them already for me. All right, so last thing, I have a few minutes left here and I'll take any other questions you guys have. This is just overall, just something that I say to everybody. You're going to see anorectic patients on ER. You're going to have clients come in, my dog's not eating. Some of them are going to have bad mouths. Some of them will have horrible perio. Some of them will have broken teeth. Some of them will have broken jaws. Some of them will have stomatitis. Bottom line is 99.9% of the time, it's not the mouth. Unless it's caudal stomatitis or a mass that the dog can't eat through, something that is the worst mouth you have ever seen, not the mouth. 99.9% of the time. Always, always, always take it with a grain of salt. Here's a dog with horrible osteomyelitis. His entire right hemimandible, dead, necrotic, infected, eaten great. Dog, a cat, or that's actually a jaguar. That's the Balba. If any of you guys have heard that story. He's got a complicated crown fracture. That's his nerve. Eaten like a charm. This dog's got a base narrow bite, biting into his palate, eating fine. Dog's got a huge mass, eating fine. Bottom line is, always look someplace else. So I did not do any brain breaks tonight because I didn't think I'd have time, and you're probably right. I've got a few minutes left. I didn't want to go too long, but this is just one of my examples. And if you guys have seen my Africa lecture, Africa brain breaks, and you'll know this, but I'll just give you the quick story. So those are vultures on a hippo. This is a trip that I took to Kruger Park several years ago. And this is a hippo that died about a week ago. And And he's been rotting on the Serengeti or the Kruger Plain for about a week. He stinks to high heaven. You can't get within a mile of him and you're not gagging. Well, we as veterinary professionals are used to really nasty smells, right? Parvo, maggots, anal glands, all that, abscesses, that the average person is not. So when the guides, our local guides, heard of this stinky hippo, we all drove over there. All the guides drove over there, and all of the camps went over there. Why? Because what comes to a stinky hippo? The predators. You don't see predators very often in Africa. You see, you know, gazelles, and you see giraffes, and you see water buffalo, and all the. You don't see elephants. You don't see predators. So we could see the predators during the day. Well, what ended up happening was these juvenile lions moved in the second day. Now, we saw the leopard, we saw the hyena, and some foxes. But the next day, the lions moved in. So our guides really wanted to go. Well, the girl I was seeing at the time was a vet, and I was a vet, and we're like, sure, we'll go. Nobody else would go within a mile of the stinky hippo. I mean, it was that bad. So we came in, and our guides wanted to see it. They're like, thank God someone will go with me so I can go see this, because this is the coolest thing we've ever seen. Why? I hope this video. So our guide's talking. So yes, those are flies. Yes, that's bird poop. This lion is eating this hippo that most people will not come within a mile of, like it is the best piece of filet mignon he has ever seen. He is literally fighting with other lions to defend this hippo that is rotting. So we went away that day, and we came back the next day. He's got a broken canine with pus coming out of it. This animal is eating because he knows if he doesn't eat, he's going to die. Animals will eat through any oral pain. Plain and simple, they will. So unless it's the worst mouth that you have ever seen, that animal is not eating because of something else. So again, when you have an anorectic patient that comes in, always do a minimum database. And I really throw the UA in this one as well. I think it's always important. Like Kimberly will say, liquid gold, it's really nice. But always do a minimum database. Always do full body radiographs, especially in cats that are anorectic. I'm telling you, you're going to find something. If everything is normal, you've done everything. And honestly and truthfully, in a cat whose mouth doesn't look bad, I'd probably do an abdominal ultrasound too. But always work these patients up fully before you anesthetize them. Number one, not to waste the time. Number two, make sure they're safe to undergo anesthesia. So that workup is really, 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 really critical. Okay, so in conclusions, we're almost done. There are a few dental emergencies, but these presentations do require therapy now. Why? Welfare, okay? Take care of your patients, give them pain drugs. In the vast majority of cases, except for like the caustic burns we talked about and the electrical burns and things like that, putting muzzles on broken jaws, minimum database and pain management. And I think that yellow line is really important. I don't care that the animal's eating. I don't care that he's not acting painful. They never do. Give these animals drugs. Dogs want drugs, plain and simple. If it would hurt you, it hurts them. Give them drugs and pain meds. Rarely antibiotics. And finally, client education on definitive care is absolutely critical as well. We talked about where that's going to make a big difference. What else can I offer you as far as educational resources for your clients? Well, on our website, because again, we might be doing telemedicine, even though it's not legal in most states, except for, if you guys didn't know, if you're in Arizona, you can do telemedicine now. They've actually allowed telemedicine, but nobody else can legally. But if you want to give your clients some information that they want to be able to find out, why do I need to treat my dog's broken tooth? Why do I, because you're not having these face-to-face. These are client educational videos on our website. It's just Dog Beach Vet. You see at the very, very bottom there, Dog Beach Vet, pet owners, pet dental education. If they go onto that, those are the way I talk to my clients. They're videos, they've got pictures, as you can see, x-rays, everything that talks about abscess teeth, stomatitis, cancer, hypoplasia, cysts, periodontal disease, everything's in there. So you can just talk to your client, maybe they sent you a picture of a fractured tooth and say, go to this website, listen to Dr. Niemiec, and then come in and let me pull your dog's tooth. So it's really nice, especially today, to be able to use these audiovisual aids to educate your clients. If you guys want more online education, like I said, I will be doing some of these free things, hopefully weekly, and I need to talk to Covetris about borrowing this again because I don't think I'll have my platform set. But I have a full 16 or 15 module series on how to become a dental concierge, how to talk to your clients about why they need to do dentistry. So if you guys are interested because you're either off work or slow at work and you want to get some CE, it is RACE approved as well. And this is our website. If you go to our website and on the top of the page, you'll see the veterinarians thing. If you tab onto that, the drop down will see Veterinary Dental Training Center. Where you guys registered is the free veterinary dental CE events. Go to below and go to online training and it'll bring this up. There's a little teaser on there so you guys can see what's going on. And I am going to work on a lot more online opportunities as well. So that is my lecture. I'm hoping that you all enjoyed it. So I am going to start answering questions here. And once again, before you guys start signing off here, we've lost a couple. We just for everyone knows, we had 311 people at the top. So I'm going to answer these questions and finish my wine over the next little bit until you guys are bored of me. So someone else had asked about Convenia, about being a good antibiotic. It is. It actually has a dental label in Europe for dentistry. I don't think it's the best antibiotic for the mouth, but it does cover quite a bit of it. I still prefer Clavamox. Clavamox is always going to be my best. But again, if you've got to get something in the animal, it definitely works. You know, it's really funny. I had tongue lacerations in there, and Kimberly said, I don't think you have time to discuss that, and I took it out. Tongue lacerations bleed a lot. The good thing about, you know, anything in the mouth, but especially the tongue, is that they heal really well. They really do want to heal. So what it really comes down to is minimal debridement, and have good hemostasis, and then just suture it like you would anything else. Dogs do really well without the tongue. So if you're really concerned about a dog that has a lacerated tongue or cancer or something, you can cut it back. Cats just really, really don't. Absorbable suture, I use gut, to be honest. I use gut. Are broken teeth in puppies with deciduous teeth an emergency? I think so. I mean, if you've got a broken deciduous tooth, you've got an exposed nerve. I think it hurts. I think it needs to come out. The other reason that I think that deciduous teeth that are broken need to be treated right away is puppy teeth necrose pretty easily and quickly. And if they necrose and they start draining before you know, down onto it, the puppy tooth apex is right above the adult tooth as it's developing. And so the infection is draining down onto that adult tooth, and it may actually create enamel hypoplasia in the adult tooth. It's been reported. So yes, I think broken teeth in puppies with broken deciduous teeth in puppies should be treated right away. I'm thinking some good feedback. I think that everyone's enjoying this. Treatment of papillomatosis is generally self-limiting. If papillomatosis is really bad, I would get a biopsy of it, and there are some treatments, but in general, it's self-limiting. You can biopsy it. They talk about crushing and things like that, but I don't generally treat that very much. Yeah, I can share the recipe for Magic Mouthwash. What I'm going to do is send out an email with the recording. So I will send an email to everybody that registered with the recording on it once I get this from Covetris. And again, thank you very much for Covetris for letting me use their system. But I will send out an email to everybody that registered, and I'll put the Magic Mouthwash recipe on there. Again, it's in the emergency book, but I'll put that on there, as well as if anybody is watching this that maybe their friend would like to watch it and get the CE, there is going to be questions that you have to answer. So I'll have a link to that probably middle of next week. As far as cyclosporin for stomatitis, we, in our experience, we're about 90% long-term successful with just the extractions. So if we get to it early, okay, it'll fix it most of the time. The animals that don't get better with full mouth extractions are the ones that have been on steroids for a long time. So get the extractions done quickly. If they don't get better, that 10% that don't get better, because some don't. Cyclosporin works the vast majority of time. I don't know if I have a number like 95%, but I would say the vast majority of time. So 95% may be accurate as far as those. But again, all the teeth have to be taken out. Let's see. All right, so on a personal note, someone asked if I'm on keto. Yes, I still am on keto. I am drinking, if you guys are keto and you want to stay low sugar, dry farm wines. Okay, dry farm wines is almost no sugar. It's like 6.6 grams of sugar in a whole bottle, and it's a little bit lower alcohol. Let's see, Miracle Mouthwash, I'll send it to you. Yeah, dry farm wines. I can't remember, it's a French one, something like that. All right, I think I've answered all the questions. I'm happy to take emails at some point, but it is 6:45, and I'm glad that all of you guys have enjoyed this. Do I check my chat? Real last quick question. Do I check my cats for toxoplasmosis? No. No, I don't know that I've ever really seen that as a problem. So, all right, guys. Thank you, Matt. Thank you, Covetris. I'm going to sign off, and my hopes would be next week we will do another one. So we'll work on it. Just follow Facebook and follow Constant Contact. Have a great evening. Stay safe out there. Greetings from San Diego.